Much, Brian, and welcome everyone. I am very excited about this panel and this topic, pilot purgatory. I love seeing that in writing and love to have this conversation with this fantastic panel. So again, this is your opportunity to really learn from experts and pose all sorts of questions. And what we're going to do is really have a conversation around what this means and what this looks like. And so with that, let me ask Muriel Bean to first introduce herself, and then Melinda, and then Lisbeth.
Good afternoon, everyone. I'm Muriel Bean. I serve as the Senior Vice President, Chief Health Informatics Officer for Trinity, and I'm also a proud ATA board member.
Hi, nice to meet everyone. My name is Melinda Cooling, and I serve as the Chief APP and Nurse Executive for OSF Healthcare in Peoria, Illinois.
And I'm Lisbeth Troop. I'm the Chief Clinical Officer for AvaSure.
Great. Welcome, everyone. And please with your questions. We're really excited to glean as much as we can from this terrific group of experts. Let me start with my first question, which is just to get the ball rolling and ask each of you to describe your experience with pilots. And I'd love you to include details on the most memorable experience you've had leading a pilot in your career. It doesn't have to be at your current place of employment. What did you learn in that experience that you'd continue to do or that you avoid now based on that experience going forward? So Melinda, let me ask you to start, please.
Sure. So I guess I've had the luxury to be involved in a lot of different pilots across my career. One memorable one for us was when we were starting a new urgent care model as part of our healthcare system. And we called it a new urgent care model because it was very focused. It was APP driven, the model of care, and it was a very detailed group of diagnostic criteria that the patient had to meet. What was different was that we already had other models within our healthcare system. So you can imagine that right off the bat, everybody got a little frustrated that why are we starting something new? Why are we pivoting this way? It really started our digital transformation within our healthcare system. That was some of the early work that we did because that was the launching ground for us to add a lot of our other digital health opportunities that we have now spread across our organization. But it was memorable because it really created a huge pivot within our organization and made me grow as a leader from the standpoint of dealing with things like change management and really being able to have those conversations with executives and clinicians at all different levels to really be able to articulate the why. Why is our health system going down this road? Why is this part of our strategy moving forward? And so I would say like the things that I learned the most through that is really understanding that you have to have a really strong system strategy to be able to articulate your why. Because if you can't really say, this is the strategy, this is one step to start getting us down the point of doing our digital work that we plan on doing, and really defining our success metrics. So how are we going to evaluate ourselves? How are we going to know that this is working, that we're meeting the needs of our patients when we do this? So for me, it was I remember it so much because it was so impactful to me from a personal and professional growth standpoint within the organization.
That's marvelous. And I really do like start with the why. So I think that's really fantastic. And is there anything that you learned in the process that you avoid doing now?
Well, I think that I sort of came in this. I think of myself as a clinician that's pretty open-minded, like I'm okay with change. And so I really came into that somewhat immature and thinking that everybody felt like that every clinician was ready for change and everybody wanted to jump on board with the next best thing and help move our system forward. And what I really found was that there's a lot of people who don't like change and certainly did not appreciate my passion around it at the time. So it just taught me some lessons around how to manage change management and really look for the different types of clinicians that you're working with.
Yeah, I think that change is hard, and we'll talk a little bit more about that in a minute. Muriel, if you would share your experience. and what you've carried forward.
Well, there's one point that I wanted to make or highlight what Melinda said about I guess that optimism, Melinda, I did share in some of my pilot experiences of, oh, everybody's gonna love this because I love it, right? And all the change is great, not, and it wasn't. And that was one of the, I would say, one of those lessons learned that you take to every, if it's a pilot or whatever innovation that you are trialing. And that is one of the areas that, as I started to evolve my thinking and the way that I did and think about buy-in, getting people to understand the why first, to the point that you made, Anne, is really critical. Because that enthusiasm of saying just because I like it, and you just have to understand that this is great because I think it's great, is not enough. And then the thing that, whatever that introduction of why we are taking this innovation or whatever it is and putting into pilot and looking at whatever the metrics that you've decided or whatever that phase of innovation that you are trialing within the pilot, and then the why, making sure that people understand that why. It's really critical to get that upfront, um, that understanding. It's really critical and important to get that done to begin with. And then as time went on and as time goes on, that's one area that I tend to focus on, is to make sure that people do understand that why, and that buy-in is something that I always reiterate and refocus on, even iteratively through the project and through the pilot, to make sure that we're all still anchored in our same why, right? And understanding that we're still moving in the same direction and making sure that we're all still saying, this is why we're doing this, right? And we understand that this is what our goal is. We're all in this together. We're still trying to do this for the same purpose and reason, to still continue to remember so we can all continue to ground ourselves. That's important to do that in multiple phases through these types of projects.
That's great. That is fantastic. Is there anything else you want to share about your pilot experience? Otherwise, we'll drill down later, but
Well, that was when Melinda was saying about the enthusiasm and all that other thing. That's what brought to my attention, is one of the barriers sometimes in these type of events or these type of pilots, of that enthusiasm. If you don't continue to remind people of the why, I think is one of my biggest lessons learned, is just to continue to keep that front and forward.
perfect. I think that's great. Simon Sinek is big on that, right? Why, his TED Talk. Lisbeth, please talk about your experience.
Mariel and Melinda, your enthusiasm and optimism just kind of reminds me of myself. And I think I'm thinking of the very first pilot that I led in my career, which was probably over 15 years ago, as a youngish clinical nurse specialist. And I kind of got carried away, and it blinded me to where this pilot was failing, which was on the workflow side and the technology side. So it was it was ahead of its time, and it was an early warning score. I was responsible for rapid response and kind of early warning in our hospital. And there was a startup out of the UK. They had this special algorithm, and if you had real time patient continuous vital signs, you could, really predict which patients were going to deteriorate. The problem is we wanted to test it in med surge and intermediate care areas where you're not doing real time vital signs. So I was kind of like forcing people to more heavily monitor these patients. So hardwired to 5-lead EKG, pulse ox, blood pressure cuff was squeezing very frequently. And the kicker, this is so embarrassing. The kicker was they wanted a skin temperature, like a constant temperature. So I got skin temperature probes from the OR, which are for unconscious patients, and plastered them in patients' armpits. They wouldn't stick because they got sweaty. So let's take chest tube tape and like make sure they and needless to say, there was a lot of pushback from the nurses and the patients. You know, the rare occasion, there were a few like early deterioration that we saw, but wearables were not where they are now. AI was not where it is now. And I eventually, you know, realized that we had to admit defeat. And that is the lessons that I've carried with me since then. It, check with the workflows, make sure that, you know, on innovation, timing is everything. It makes sense, it should work, but are we really ready for prime time?
That is a great point. All great observations, and a reminder really to everybody listening in that you have questions. What you're getting are really candid insights from our panel. So thank you for that.
And may I add something to what Elizabeth said real quickly?
Please, please.
Another point that Elizabeth just made for everyone who's listening, and it's a really important one too, especially in a pilot. One thing that she recognized, even though through her laughter, she recognized the failure. You fail fast, you pivot, and you move on. So that was the other piece that, Anne, you were asking about some of the things that, some of the lessons learned from a pilot. You recognize what you've done, you acknowledge it, address it, move on. Fail fast, acknowledge, move on. Okay, that's it.
Exactly. This is what we mean by purgatory. Like, purgatory is limbo. Like, you're not moving forward, you're not moving backward, you're
Yes,
stuck. You
you're
know, so
stuck.
what
Yeah,
we're saying
exactly.
is, I think, you know, the conversation is about either you're going to move forward or you're going to move backwards, but don't just get
Exactly.
stuck. Yeah.
Yes, exactly. I just wanted
That's
to add that part.
No, I think it's great. Thank you so much, Muriel. Um, I want to move on to a topic that was raised during our prep call, which was the adoption of virtual sitting and the timing of when that happened in many organizations, which was, I think, at Trinity, for example, around the time of the pandemic. Um, and we talked about it because it was several years ahead of the adoption of virtual nursing. And the ROI had been, in your estimation, collective estimations, probably easier to demonstrate. Can you talk a little bit more about that and how the adoption of virtual sitting has informed other work that you've done within your organization? And Muriel, do you want to start, please?
Yeah, I could kick this off, and Elizabeth, you can jump in and anything could correct me, anything that I missed here. So for virtual sitting specifically, when we initially began our virtual sitting journey, we actually initially thought it would be a 3-year journey for us, for Trinity. What happened is COVID happened. And when that occurred, at the time, our chief nurse executive, Dr. A. Landstrom, and our chief executive officer, Mike Slabowski, they came together and there was a need or a desire to increase. We had staffing shortages. Everyone was having staffing shortages at the time. So during the pandemic, we saw that we need to accelerate. So we shortened it to like 9 months. Where we saw our greatest at the time, our greatest ROI definitely was in staff. So we saw the decreased need of what we at that time was the patient centers. We saw the efficiencies that we can use technology to support what we call patient sitter attendance using a virtual care platform. And it gave us the opportunity to actually give us the opportunity to have more visibility and give us more, we could have more visibility, more patients. And so we increased our safety, we increased patients to be more safe in their environments, and we needed less people to do that by using technology. And so with that, and to Anne's question or to Anne's point, we were able to actually see that ROI very quickly. I believe, Elizabeth, you can keep me honest. I believe our first year we were able to see that like $23 million cap in staff cost reductions. I think our total to date, if we did our 12-month rolling, I think we're at 33 million in cost savings, where we look at from our cost savings there from staff reductions or needing staff reductions in that area. However, what we started to then see is that there's a potentiality for this type of, when we think of staff and we think of utilization of technology and with staff and looking at different modalities of care, we did try to see that if there were different implications of that in Trinity. And so we did use a pilot type structure to start to support that. And we did advance that in a virtual care, virtual nursing type of care model. And that's what we did that at Trinity. So I don't know if there's anything else that you wanted me to add or anything, Elizabeth, you want to add to that.
I think a catalyst for that, like you mentioned, was COVID, and it was to scale across every hospital with 2 hubs. So there's one hub in Chicago and one in Connecticut. Chicago and Connecticut, monitoring patients all across the country and all the Trinity ministries. So that was a big lift. That's why it was a 3-year plan, and in between, and I remember seeing this huge project plan in between where it's epic go lives. So we were kind of working around the epic go lives, but when the crisis came and the crunch, there was a sense of urgency, and that moved all up in front of epic in a 9-month rollout across the whole system, which was very ambitious and which was accomplished. And then we could distill it down to per hour cost. So Trinity provides 3 million, 4 million hours of patient safety monitoring from those hubs a year. And the total cost is less than $3 an hour because of the efficiencies and staffing and technology and the centralization versus, as you can imagine, one-to-one sitters being like $18 at least an hour for that. I actually met a nurse from the VA who said that he moonlights as a sitter and gets paid time and a half and gets $76 an hour for patient sitting. So $20 an hour can be an underestimate on that. But so yeah, that was, I think, and I hope we talk about that a little bit more throughout our conversation about what the catalyst can be. And how to create urgency and to, get out of being unstuck.
It's a great point. Melinda, any experiences you want to share in virtual sitting to virtual nursing?
Yeah, I would just share, we were in a similar space with virtual sitting. Like we sort of started that right before COVID for the same reasons of really trying to look at how do we maximize our nurses' role, understanding that we had patients that were sicker in the hospital. We had behavioral health patients. We have patients with dementia that required sitting. Was that really the place where we wanted to utilize our nursing resources? And so we used CNAs or other technical type roles to help us do that, as well as the virtual option for those patients that were safe to do that. And so again, it just extends the scalability of the program and being able to put that there. And many times that's all the patient needs. They may not need it in person. And so virtual is sort of our first line. And then it's, if they become if you have a really combative patient or somebody that you just can't keep in bed, we can do that. But that experience that we had also led us to be able to really launch our virtual nursing, which we've done we started about 2 years ago. And I think for me, what I really want to get out of that is the change from when a nurse on the unit is really busy and she's trying to discharge a patient so the next patient can come in. Oftentimes you see them, they take in this after visit summary and they go through this slew of information for the patient and their family, and the patient leaves and they're like, what did she just say? They get home and they're like, what was it she said about this medicine? Or he said, when is it I'm supposed to follow up? They get very confused many times. So I find that our virtual nurses are able to take a little bit more time, do a little bit deeper teaching with the patients, make sure that they truly understand where they're at, and sort of take some of that off of the nurse that's at the bedside caring for many other patients. And so I think we're just on the cusp, honestly, at our organization of what we can do with virtual nursing. I'm really excited to see some of the even new technology things that are coming, and for us to be able to spread that, because I think there's so much opportunity that we can have with that and really take some of that burden off of the nurse who's caring for 5 to 7 patients sometimes.
That's great. And I think our audience really liked that as well by the emojis going up. If we could just pursue this a little bit more, let's assume some on the webinar are relatively new to leading pilots. We've touched on urgency as being an important catalyst or other catalysts. What are the key elements that you need to ensure that the pilot goes well? With that, then, how do you create a sense of urgency? It could be vision, but it might be other things as well. So, Elizabeth, can I start with you and ask you to draw on your own personal experiences as well as the work that you're doing with so many organizations out there?
Yeah, creating a sense of urgency is a good question, and I think is the crux of how you can get unstuck. In my clinical brain, I often go back to the Iowa model of evidence-based practice, which you must start with a problem to be solved first, and then the very first decision point on the Iowa model, and in my mind, is that aligned with the organization's needs and goals, and then you can move through the process of pulling a group together and deciding what your KPIs are and the governance to support it, and then that's when you finally pick the technology and where to do. Lastly, when you pick the technology and where to do it, and then set really good expectations on that. And so I think that's a process, a formula that works well. But we were talking about urgency, like COVID created urgency. And right now there's urgency with revenue, crunch coming up next year, and then even more so the year after that. So I think that's where we're seeing that, and how do we use that and not in a way to where normal circumstances might not help us move through as quickly. So when stakes are high, decision making kind of accelerates, and sometimes the barriers don't seem so large. And that takes a kind of a leader who is an expert leader who can do kind of intuitively grasp this complex situation and make some intuitive decisions that aren't solely based on past experience and guidelines and rules.
Yeah, I think those
Like Jay and Mike,
yeah.
Slabowski, yeah.
Yeah. Well, and also having that vision and that intuitive sense also goes back to the why, because you put the why in
Yeah.
terms that people can
Yeah.
engage with. So, Melinda, what about you? What are some of the key elements that you think, and talk to us a little bit about agreeing on KPIs? What's the length of time you'd use for a pilot?
Yeah, so I mean, most of the time, I would say that the first line to me is always looking at what does the evidence tell us that we should do? Like, and why do we have a problem? To Elizabeth's point, like, why do we think we have a problem? Is it a real problem? Is it a perceived problem? Is this a pet project, for a leader? It could be any of those types of things. And then always coming back in our organization to saying, is this aligned to our strategy? Because whether it's an expensive project or not, like when you think about if you're adding technology, there's always the expense of your human capital, right? You have a leader attached to it, you have analytics attached to it, you have employees that are attached to it. So I always think about, if you can't attach it and really connect it to the strategy of your organization, then you shouldn't be doing the pilot to start with. The second thing is, I would say, making sure that you define your success metrics. And most of those you should be looking at within like a 3 to 6 month period. And you should be starting to see by then that this is either going the right way and being able to pivot on the fly. So again, like if you know things aren't going well, even though you're 1 month in, then it's time to pivot. Like you don't say, well, I'm going to wait for the 3 months and see if it gets better. Most of the time, it's probably not. And so being able to pivot and pivot fast, sort of the fail fast and being able to pivot. And then also like being able to, I always say this to my team, like we have to be able to call our own baby ugly. Like sometimes you do a pilot and it just is not good, right? Like you've implemented something that doesn't work. It could be for a variety of reasons. Like it's okay to say that. But laying out those success metrics, saying like this is what we are trying to achieve, and that may be labor costs, that may be integration of technology, that may be some of the change management, it may be something that's better for your patients. And then last thing I would say, the workflows are so, so important because this is where I see anymore with the technology piece. Like as a clinician, if it's not part of my everyday workflow and how I'm caring for a patient, then I'm not going to do it, right? So no matter how many change management tools you bring out on me, if you don't embed it in my workflow and make it really easy for me to do the right thing, then you're not going to get adoption. So I say that from a standpoint of like, if you're bringing in a technology vendor and it doesn't integrate in your EHR, whatever that should be, like we're an Epic shop. But my thing is if our clinicians can't see it, then they're not going to utilize it no matter how many times. And so that has been a really strong philosophical thing that we've really brought into our organization to say like, it has to be part of their workflow. It can't live completely outside of that. Otherwise, we just know that our clinicians aren't going to adopt it well, which then in turn is not going to influence the care of our patients, which is what we typically are aiming for when we're trying something. So those are some of the key things that I feel are really important.
This is wonderful. Muriel, please add.
I feel like Melinda said it all. I mean, I couldn't say anything more because I was going to start coughing really badly, Melinda. But the only thing that I would add to what she said, because the workflow aspect is one aspect of a pilot that people tend to forget. So if you're not an informatician or you're just a good logistician, Melinda, you're welcome to become an informatician, an honorary one, because that's one that people often miss is that integration piece of the workflow as it relates to a pilot. The other aspect was, and it just went out of my head, but it was more of the alignment of the KPIs. When we're looking at KPIs, we have to ensure that the KPIs that we're aligning actually is aligning with the KPIs that we want to look to our new work processes, not our old. So sometimes we tend to map our work to what we used to do. And I don't know I don't know what that phenomenon is. I have not quite put my hands on it, but we tend to look and we define what we think our future is, but we define it from looking in the rearview mirror, not looking at what we're looking going forward. I don't know, Melinda or
No,
Liz,
I know
if
what
you
you're
guys
saying.
know if I'm
Yeah,
trying to explain what I'm saying right.
it's almost the mistake that we really made when first implementing electronic health records, or we just kind of took the flow sheets and tried to, digitalize them
Yes,
rather than just really making it transformative. Yeah.
yeah. Elizabeth said it better,
No,
but it's
that's what I was thinking when you were talking about that. But it's
and
hard to imagine something that even isn't, you know, not what we've always done. Yeah.
it's hard because then we start to think of new processes, but we're thinking of all ways of defining it.
Yeah.
And then we continue then to try to match our progress, but we can continue to think we're failing, but we're not because we're actually measuring the wrong things in a pilot.
You know what I love about this is that not only are you talking about the pilots, but you're also underscoring what has made the digital transformation for organizations work as well. So you don't start with the technology, the shiny object, you start with the problem you're trying to solve. And as a organization that provides solutions, sometimes your baby is ugly or your solution is ugly, and which I'm not going to forget that ever. And then the workflows, how essential it is to put that in the process. So much wisdom coming from this group, and please, audience, post your questions.
And
This-
I'll just add one more thing about your point you just made about the tech from a technology standpoint. I've really had to challenge our clinicians lately as we've thought about some of our different practices. But I also think that we can get in a habit sometimes of over engineering, like our EHR, for example. And I'm going to use the example that I've been harking on with falls lately. So patients that fall, and we have a fall risk tool assessment that we use. And then when we have a fall and we're looking back and doing an RCA, I may have a nursing leader say, well, the patient came in because she fell, but it didn't trigger the fall assessment because the fall happened outside of the hospital. Now, to me, I'm like, that's where our clinical decision making has to come into play, that the patient's a high fall risk, period. Doesn't matter what the EHR tells you. That's one of my concerns that I've sort of started to see lately, is that with all of our technology sort of transformation, while it's great, we have to really be careful about not over engineering it so much that our clinicians don't use their clinical minds. Because it's really important at the end of the day, like, it's a tool for you. It should not change your clinical decision making. Like, as a nurse, you should be saying, doesn't really matter what Epic is saying to me right now. This patient came in because they fell. They're a fall risk. So
the digital transformation shouldn't be a brain transformation, right?
Correct.
It should not take away the critical thinking.
Right.
We still should think.
Yes.
I think this goes so well, Anne, and maybe you were thinking the same thing, into ambient documentation for nursing. Were you thinking the same thing? This
Please,
is like,
go ahead.
it's like a planned transition into that
Melinda's
topic.
fault. It's all Melinda's
Yeah,
fault.
Melinda,
Blaming
like
it on
you
Melinda
just
because I'm sick, so I
set
can't
it
take
up.
the blame.
But when I think that an example of this that we are looking at right now, and Muriel and I were talking about it earlier this week, is ambient documentation for nursing, which we've kind of already done for physicians, but as in hey, what about us? There are a lot more of us doing a lot more documentation. But as we're doing that, how does that change how we practice nursing? And we have to think about that. And Muriel and I were talking about the concept of having to nurse out loud. If you're going to be using ambient documentation, which would make nurses' critical thinking more visible. Because in highlighting the complexity and the value that we bring to our assessments and decision making. But at the same time, like a little bit of caution on that, and this is what I love that you brought up, Muriel, is that nurses are often, they will have to speak in like very accurate clinical terminology in order for accurate capture. And that may challenge patients with that, when we're trying to meet their health literacy and their understanding level. And it's our role, and always has been, to provide that holistic patient-centered care, especially in the communication. How many times have we rounded with a physician and then stayed behind to translate it? And so I think, Melinda, your point about the falls and the clinical critical thinking is what we have to be thinking about as we're moving into ambient documentation.
That's great. Melinda, is there anything you want to add to that, or Muriel?
No, I would agree. I mean, I think this is a space we haven't really gotten into yet. We have some work to do on our sort of our EHR to prepare us to get ready for that. But I'm really excited to see, because I do think, again, it can capture some of the things that maybe nurses aren't great at just documenting. I'll use an example, like and our CNIO brought this up to me, and I don't think this happened here, but maybe she learned it at Epic. But we're a faith-based organization. So many times, our clinicians, our nurses, doctors may ask a patient if they can pray with them. And so that typically is not something that you always see documented, but the ambient listening will pick that up. and put that in there, which is depictive of, sort of the mission and values of our organization. Just as an example. So I'm excited to see where it could go. I think Elizabeth makes a great point about sort of the terminology and the connection of the nurses and patients that may look different than it currently does for physicians.
When Elizabeth and I talked about this the other day, that was one of the things that came up actually about a year or two ago. There was an organization or a vendor that with the prior CNE, Dr. Gay Landstrom, that was with Trinity. When they approached us, that was one of the first things that came to mind for me is when they started to talk about the very structured way that this ambient tool was going to, it was so unnatural. It was the thinking out loud. That's why I was telling Elizabeth about it. The way that we would have to talk, it was very unnatural for us because to Elizabeth's point, it's like when we think about, we think of ourselves as these human translators at the end of the day, when we come back into a patient's room, right? Then we're like, oh, this is really what the doctor meant when they said this. When we talk about capillary refill, this is because, your nail beds look like this. I mean, this is the way we speak. And so when someone said, well, no, when you have to document, you have to say it this way for it to be captured, it's very unnatural for us. And so thinking about that structured documentation of how it needs to be structured in the text so it can go into a very much of a form like, different way of how it has to be captured into an EHR, it's very different than for our physician colleagues, the way they have to speak, for them to, of course, get all their documentation away so they can be billed in an appropriate way. Tying it back to our very conversation here today about pilot. Now, this would be a structured pilot that I would want to see, very structured, very much regimented, very much. I would love to see what those KPIs would look like for anybody out there who has an organization that would, whoever goes down this road first with an AI tool that would look at this for nursing with this ambient type of tool, because this will be very, 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 I would say, insightful for others that would be following after of what they would be looking for and looking into, because this will be ground, breaking for all of us as nurses, as we think about documentation. As we all know, documentation takes a lot of efficiency in our workflows every single day for anybody who are nurses.
Well said.
Yeah, perfect. We do have a question, which was a question that we were going to get into anyway, about calculating ROI. And talk to us a little bit about ROI. Two elements that I want to touch on. One is, how much is enough to move a pilot into system-wide implementation? I mean, we've talked about 3 to 6 months. You should show metrics. You should put numbers on the board, or whatever the expression is. And then the second is, how do you avoid spreadsheet mania as you calculate ROI? Because if the numbers are difficult to obtain, that makes it hard, right? So who wants to take the first shot at this?
I can take a first pass. It's very interesting. Recently, researchers out of the UNC Keenan Flagler School of Business published a very good paper, and it's on ResearchGate, about the ROI for virtual nursing. And they aren't able to share which health system they looked at, but they really showed a decreased length of stay and decreased readmission rate. But I had the opportunity to talk to the authors last week, and it was thousands of lines of code written in Python by a PhD student, hundreds of spreadsheets from many different sources. And then when she finally said, "Oh, and a brilliant PhD student, well, oh, and I also got this help from this economist at Duke who happens to be a Nobel laureate," I thought, "Oh my goodness, no wonder, at health systems where you're lucky to get an analyst, you just don't have the resources to dive that deep. So on some levels, there is that sort of intuitive leadership of knowing that it's the right thing to do and moving forward. And I think Muriel, I think your CEO, Mike Slabowski, is one of those intuitive kind of leaders. And you talked about deciding to expand your virtual nursing pilot after 64 days. And now you're in 2010.
Yeah, I mean,
So,
and it just depends. Too, we didn't have any kind of we had goals. We did set some of our measurements. We did, it wasn't sophisticated. We just kind of went with it. To Elizabeth's point, I mean, yeah, you can have these set of sophisticated measurement structures if you'd like, and you can be an analysis paralysis and you can have a defined time to do that. But then there are times where you just have to make a decision with your gut. It was 62 days that there were some of our measurements that were decisionally, they were going in the right way. They were, trending in the right patterns. And so we have a governance group, a governance team that oversaw our virtual care strategy, and they were like, just go. And so that got us out of pilot purgatory. So we got to move on, and we definitely took that, our pilot, and we implemented it across our organization. And yeah, we're in almost 2,000 beds. And so it just depends on your organization and where their risks are and where they're willing to take their risk. If they want something more concrete versus something that they're just willing to kind of go with too. So I think there's a lot of dependencies there on what your organizations are willing to do there.
Linda?
Yeah, I would just add that I think, sometimes when we think about ROI, we get really caught in the financial ROI. And there's a lot of other sort of ROI metrics that you can look at. So sometimes it may be your clinical outcomes, it may be throughput gain that you get, it could be labor optimization, could be things around patient experience. And those are all really important. And yes, you have to be able to financially support the program. But I think sometimes if you get in a habit of like the ROI is only a financial ROI, it can really pigeonhole you into your growth strategy. So just thinking about like, yes, this may cost the organization a little bit more here, but we're gonna gain it back on our patient experience or our throughput, or look what we're doing with clinical outcomes. And if you're an ACO organization, those are gonna be things that those dollars come in a different way. So just making sure that you have somebody that's able to really see the big picture, because you can get really caught up in just looking at like a project and saying, you have a financial person that's saying, well, this isn't worthwhile because we don't have enough money coming out of that. I feel like sometimes you miss the mark thinking that way.
It's so interesting that you put it that way and touch on some other things, because I would say that one of the best ways to engage skeptics in the process is say, well, here's another measure, and let's make this assumption that it's X. And here's what we show, because it all translates to money one way or another, even your soft ones. And the skeptic can say, well, I wouldn't say 50%. I would say, let's say 20%. Say, fine. And you engage them in the process, and then you start shaping the KPIs as well. Which brings me really to the last area I wanted each of you to comment on, and there was a question about it, is your approach to resistors. So you've all talked about focusing on the why and articulating that, being, oftentimes acknowledging that people are afraid of change. Not everybody is fearless like the three of you. So can you talk a little bit about, what's worked in terms of getting people on board and, other techniques that you might volunteer in terms of moving people along and forward, recognizing that it's not one and done. You have to do it over and over and over again. So.
Yeah, I can start. And I think I would say being an advanced practice provider too by background, like I feel like we've had to pave the way in this world anyway, from that standpoint is like sort of talking about your role. But when you think about resistors in general, typically there's a reason that they're resistant, right? There's some kind of fear that they have. They're concerned about a financial impact that may eventually come to them. There's some kind of deep-seated reason that they usually feel that way. And so what I've sort of done is be able to have one-on-one conversations with them. Like when I find people that are just really resisting, getting them in a room and saying, like, let's just have a transparent conversation. Like, what is the reason that you're so against this? And how is this, are you willing to hold the strategy of the organization up because of your one opinion and how we think this can provide better care to our patients? And I think anytime that you can, if it's someone with a clinical background, if you can really showcase the impact to the patient, most clinicians will eventually sort of turn, right? I mean, we all got into clinical medicine to care for people and to provide a difference in clinical outcomes. So typically you can start to turn them. And then if you can get them to really open up about, this is what I'm actually worried about. And sometimes you can say, okay, that's a fair concern. Like that's on our roadmap to look at, of how this may impact physician compensation, or how it's going to impact your panel size of your primary care. Those are common things that we've sort of encroached upon over the last several years. But I think as an organization, the only thing I would say is that you also can't let those people hold your strategy back. At some point, it's like you have to manage them up or they have to be managed out, because you can't hold up a system strategy for individuals who cannot come along within your healthcare organization or are so resistant. And I think that's really difficult, right, to do. It's much easier for me to say that on here than do it. But it's really important that we start to do that in healthcare, because we can't financially afford to do things the way that we've always done them. And it's not the right thing to do for our patients, right? Patients are looking for care delivered in a different manner than they were 20 years ago. And we have to adapt to that as a healthcare industry.
Amen. I was writing something down and a comment came in, agree to disagree, and commit, which I think is like fail fast. Muriel, anything you want to say or add to Melinda's comments?
Persistence. And so it's a lot of what Melinda was saying, try to find common ground. So trying to understand similar comments to what she said, trying to understand the why, but also not allowing that to become the barrier to achieve your goal. Because you can't stay, it's almost like to the point that what we're talking about here of almost staying in purgatory. I don't have, I mean, I'm going to say this very directly. You don't have time to kind of hold the hands. You have to figure out what's the resistance, try to figure out some common ground. But sometimes common grounds are just political and there's no why behind it. It's just because. Okay, so then we have to go back to the common good and the greater good. So what are we doing here that's for the common good and the greater good of what we're trying to do? We're trying to save patient lives. We have a bigger goal and bigger vision here, and let's keep that in mind and let's go achieve that part. And so that's what I do each and every day when I think about these type of things and when I try to, overcome these type of barriers, especially human ones.
Great. Elizabeth, thank you for sharing the citation. And
I
any,
shared it in
yeah,
the hosts and panelists, but you'll need to share it
I will
over
do
to.
that right now.
Okay.
Perfect. I am sharing that now. And anything that you want to add?
I think what I really heard both Melinda and Muriel talking about is you can't bring facts to a feelings fight sometimes. And, and so like I think you validate and understand people's feelings, and it's fear, it's cognitive overload, and what you do. I kind of go back to storytelling because my dad was a preacher, and he told some good stories, and we had a panel with Hackensack, and they have gone virtual nursing across multiple hospitals. And one of their leaders was talking about one of their big detractors was a nurse who'd been a nurse for many years, and didn't think that someone else could do her discharge as well, and she stopped them in the hallway and said, you know what, for the first time in I don't know how many years, I get to feed a patient. And she said, I'm Italian, and for me, feeding is so much more than just feeding. It's nourishing, it's loving, and it's a way, and it was a time for me to connect with that patient and have a very therapeutic conversation. And so that story, when you share that, I think to your Melinda's Memorial's point, it gets back to patient care. And so I love storytelling.
I love this conversation. This was so rich. It was such an honor to be with the three of you. I have many notes and just lots of learnings. And thank you for sharing your time and your wisdom and your experiences. And again, a reminder to our audience that this is recorded. So if you have other questions, I know that AvaSure has just tons of great insight, and Melinda and Muriel are available as well. So thank you all,
Thank you,
and
Anne. Thank you, Mariel, Melinda.
thank you all. Feel better. Okay, bye.